take it away.
Thank you, Amber. I'm Dr. Bob Seiss, addiction psychiatrist at Frontier Psychiatry. We're thrilled to have you join us. For today's Echo Clinic, we'll be talking about evidence that really empowers us to have informed conversations with patients about their cannabis use and the deleterious impact it has on essentially everything co-occurring within mental health. We'd like to do a round of introductions within the hub team. We're going to try something new today. If the general participants could please type in name, title, and the organization you're with, ideally also where you're connecting from, that'd be wonderful. We can do some shout outs. Let's start it off with the hub. Amber, please take it away.
Hi, Amber Rogers with Mountain Pacific Quality Health, and I'm a registered nurse.
Hi, Mary Argonis from Mountain Pacific in the Hawaii office, and I'm your IT support.
Excellent, thank you. And do we have, I'll introduce Dr. Malcolm Horn in just a moment. I want to make sure we're not missing anyone from Mountain Pacific. We haven't seen connect. Okay, great. Today, we're thrilled to announce Dr. Malcolm Horn, a very well-renowned psychologist at the Rimrock Foundation, joins our hub. We're thrilled to have her on board. Welcome, Dr. Horn.
Thank you. And I want to clarify, I'm not a licensed psychologist. I do have the degree, but I'm not going to jump through all those other hoops. But I am an LCSW and an MAC and all the other fun little initials after my name. I got to find more because whatever. But I'm so glad to be here. This makes me happy. So I'm so glad to be a part of this and I appreciate the opportunity.
Excellent. All right, Tamara Knotts, thanks for joining us again. Dawn Marie Thacker. We also have Eileen Ford, Sandy Crawford, Jennifer Queen, Jenna DeLeasley, Maynette Wong. And please give me a hard time as I mispronounce some names. And we will let other people please write your name, title, organization you're with, and where you're connecting from. It's great to get a mix. Hi, Mark. And so some people, so we have one person from Hancock, got Alaska, Wyoming, ×2. Got some good geographic diversity. Rock on. Let's start in on the didactic. We're going to try and keep it to 20 minutes, but invariably go over. That's okay if we do. We do have a case. Dr. Reza Hosseini Gomi has volunteered for a case. We're super appreciative. This will be interactive. I'll encourage folks to jump in and unmute at key points of this didactic so that you can share with us what you think on the multiple choice parts of it. Amber, how are we doing? Are we full screen? Excellent. So huge announcement today. Thank you so much, Amber, for all the hard work you've done in coordination and keeping the rest of us in line to get continuing medical education credit. Bravo, this is a huge deal. We're very proud to announce. We now are offering, in addition to continuing nursing education, CME. In order to get this, I'll actually let Amber take the lead on how to claim your credit.
I am putting into chat right now the link, and we're actually asking everybody, regardless if you are applying for CME credit or continuing nursing education credit, because we track all of our attendance statistics and send them back to New Mexico, which is our sponsor of our CME documentation. So if you can just click on that link, it's just basically your name and your email address and your credentials. That helps us a lot, especially because we might only have one person on a Zoom link, but there's multiple people in the room. That's not so much of an issue now with COVID, but it certainly will help us if everybody uses that link. So we'll also cross-check that with the what you just did when you introduced yourself. So if you don't do one of the two of those, we don't know you're here. So that's it. Oh, thanks, and make sure and fill out your evaluations.
Excellent.
Now I'm done.
Thank you, Amber. Really appreciate that. So quick disclosure, Doctors Eric Arzubi, Reza Hosseini Gomi, and myself are co-owners, co-founders of Frontier Psychiatry. Dr. Hosseini Gomi also has interest in BrainCheck and Biogen. Amber Rogers, you are a stockholder in pharmaceutical companies. The nurse planner will ensure that our commercial interests do not impact the content of today's clinic. And we covered both of our announcements. So today, we're going to go through how cannabis use disorder is associated with virtually every other psychiatric disorder. We're going to take a look at the evidence for the negative impact cannabis use has on mental health and identify potential interventions, as well as current forms of treatment for cannabis use disorder. Let's start off with a case. This is Miss AP, 27-year-old woman who presents to your clinic. She's working part-time as an event manager for a local company, and she's also completing her bachelor's online. Past psychiatric history is remarkable for being prescribed methylphenidate as a child. She notes, I definitely had ADHD. History of childhood physical as well as sexual trauma, longstanding depressive and anxiety symptoms, reports several failed past selective serotonin reuptake inhibitor trials. She often feels depressed, anxious, and experiences intrusive memories of past trauma, smokes 1 to 2 joints nightly to help her sleep, and she says to decrease her anxiety. Currently off all psychotropics, noting that she prefers natural substances. That said, she's now requesting a new psychotropic med trial, noting my weed isn't enough to treat my anxiety, PTSD, and depression. This is where we're going to want your help as an audience. And we have been known to cold call. Which of the following do you do? And this is not mutually exclusive. Insist on abstinence from all cannabis prior to prescribing any medication. Tolerate cannabis use so long as she's only using medical marijuana. Prescribe gabapentin as medication-assisted treatment for cannabis use disorder. Prescribe N-acetylcysteine as MAT. Engage in motivational interviewing targeting cannabis use reduction and/or cessation. Educate regarding the difference between different strains, indica versus sativa, and persuade the patient to use exclusively indica, and/or proceed to treat depression, anxiety, and trauma-related symptoms with pharmacotherapy. And so it probably came out of the presentation mode, but I don't know a good way to see the chat. Amber, this could be where—
I'll just read the chat for you.
That'd be wonderful. Really appreciate it. All right, nurse practitioner.
People just need to start typing in.
Yeah. In the meantime,
I
I think we'll ask nurse practitioner Megan Lehman what she would do. Megan? Did she hop off?
She's on, but I think she's muted.
Yeah.
So we do have Dawn Runyon says number 5.
Okay, I love that motivational interviewing. Right, you are, Dawn.
And
that
then
is certainly...
Tamara weighs in and she says 5, 6, and 7.
So proceeding to treat depression, anxiety, and trauma-related symptoms with pharmacotherapy, love it. 6, kind of the different strains.
Oh, Tamara now says, nope, not 6.
Okay, okay. All right. Okay, and here's where I cold call on Dr. Hosseini Gomi. Reza, what would you do?
I would probably lean towards 5 and 7 as well.
Okay. What about the N-acetylcysteine?
I don't know.
All right, we'll talk about that in a moment. You're all so shy. We're going to keep the cold calling going.
Okay,
So,
what's N-acetylcysteine? What is that?
Yeah, N-acetylcysteine we'll talk about in a moment. Actually, if you could hold that thought for about 15 minutes at the very end of the presentation, we'll discuss. So if we look at the evidence, as Tamara identified, overwhelmingly psychosocial interventions is where the greatest therapeutic yield is at in virtually every substance use disorder, in particular cannabis use disorder. And it turns out for patients who are motivated, there is a statistically significant benefit of using gabapentin, especially in the early phase of abstinence. And we'll discuss why the other options aren't supported by evidence. So when we think about cannabis, we're referring to a wide variety of different cannabis-containing products that, with the absence of spice and other synthetics, are all derived from cannabis sativa, the plants. Over 85 cannabinoids have been isolated. Principally, we're concerned with those in greatest abundance, cannabidiol, CBD, and delta-9 tetrahydrocannabinol, THC. THC is a CB1 receptor agonist, causing altered mood, altered cognition, and a bunch of deleterious effects we're about to get into. Whereas cannabidiol is an indirect CB1 and CB2 receptor antagonist. The jury is out insofar as definitive findings. What we know, though, based on what's come up in the United Kingdom and Israel, two countries where cannabis can readily be accessed for research, CBD may have immunologic and anti-inflammatory effects. It may also be a low potency antipsychotic, which is compelling to keep in mind. Worth noting, though, if we look at all strains of cannabis available here in the US, be it indica, sativa, medicinal or recreational, uniformly over the 20-year interval from 95 through 2014, we see a threefold increase in THC concentration. And this trend has continued. Over the same interval, we saw that the CBD concentration, whereas it initially increased, then fell off to the point now it's half of what it was back in 1995. So virtually uniformly, patients are getting higher and higher THC content in their cannabis, no matter where it comes from. And they can use it by smoking it in a pipe, a joint, a blunt, which is a big joint, tobacco water pipe, vaporizer. They can mix it with tobacco. They can ingest it as an edible, oftentimes with delayed onset of the psychoactive effects. They can also use concentrates, dabs, wax, butane hash oil, as well as shatter. These are very potent insofar as THC concentration. Let's talk about cognitive function. Which of the following statements is true? And please jump on in. This is what's going to make it dynamic and fun. Acute cannabis use is associated with impaired cognitive function in several domains. Chronic cannabis use beginning in adulthood results in permanent cognitive impairment. Chronic cannabis use in childhood and or adolescence results in permanent cognitive impairment, or all of the above. Any takers?
We got 1 and 3.
Okay, I like it.
4, 3, 4.
All right, I am going to try and call on nurse practitioner Andrea McDonald. Perhaps she has a microphone. If not, maybe her colleague, nurse practitioner Clarissa Juarez, does. Wow, people are staying quiet.
Andrea McDonald does not have a microphone.
Oh, okay.
So 1 and 3, we get most of that's
Okay.
what most people.
All right, next time we're actually going to call on somebody for audio input. There is significant evidence for both acute as well as long-term cognitive impairment in a dose-dependent manner. Cannabis acutely impairs attention, concentration, episodic memory, and associative learning. Long-term cannabis use is associated with impaired verbal memory as well as impaired cognitive processing. People take longer to process information. It's worth noting, though, for patients who began using cannabis chronically and heavily in adulthood, if they can abstain from cannabis for about a month, these impairments generally resolve. So for adults with chronic cannabis abuse, the cognitive effects are not permanent. Whereas for adolescents, it appears that may not be the case. In fact, heavy cannabis use that begins in childhood or adolescence can cause lasting cognitive effects, to the point that in this study, published by Levine and co-authors in 2017, they saw lower IQ scores, up to 8 IQ points lower, in patients who had started abusing cannabis on a daily basis by age 16, and these deficits lasted into adulthood. Of course, there were confounders all over the place insofar as adverse childhood events, socioeconomic differences, so on and so forth. All these things we know impact IQ. So the author said definite conclusions cannot be made, but certainly there's concern about the negative impact of cannabis on the developing brain. So 1 definitely is valid. 3, we just don't have enough data yet to say if it's definitively the case. How about mood disorders? Which of the following? And really would love to hear someone's voice. Cannabis use is associated with higher severity of mood symptoms in depression and bipolar. Cannabis use is associated with lower rate of major depressive episodes. Or there is no increase in the rate of cannabis use disorder in patients with bipolar disorder.
We do have a comment from Don Runyon that the
Yes.
behavior and genetic literature supports that heavy use contributes to the onset of schizophrenia.
We're about to get to that. Hold that thought. I like it.
Okay.
All right. Shauna, would you be able to tell us what you're thinking? Shauna Johnson?
I'm actually thinking of number one, probably.
All right, I like it. Thank you. Let's take a look. We know from a secondary analysis of over 43,000 US adults, there was a 2 to 3-fold higher rates of lifetime cannabis abuse among patients with depression or bipolar disorder. In a 2018 systematic review, recent cannabis use over the 6 months prior to when the study was conducted was associated with a higher intensity of mood symptoms during subsequent follow-up, meaning that be it depression or a manic episode, it was very likely the symptoms were more intense in those who were using cannabis. So there's a significant association here. Is there a causal link? In another meta-analysis, we saw that heavy cannabis users had significantly higher rate of major depressive episode versus those who abstained or only used on occasion. It remains unclear, though, if there's causality. Twin studies support the hypothesis that the comorbidity of cannabis use, abuse, and depression is likely due to a third genetic and/or environmental factor predisposing to both disorders. So in this case, it may not be causal, but comorbid because a third factor is driving it. How about bipolar disorder? Lifetime rate of cannabis use, abuse in bipolar disorder is nearly 1/3, 30%. Compare that to just 1.5% in the general population. Significant association between cannabis use and both earlier age of onset of the first manic episode and a higher frequency of mood episodes. Cannabis use is also associated with a 3 times increased risk for new onset of manic symptoms. So definite association, can't comment on causality based on the information thus far. We can say there may be third factors, genetic and/or environmental, contributing to both cannabis and mood disorders, and one is the right answer here. Go Shauna. How about psychosis? Which of the following is true? Cannabis abuse is associated with a higher lifetime prevalence of schizophrenia. Various case reports demonstrate an association between use of high THC content products and psychosis. Onset of cannabis use in early adolescence is associated with a significantly higher lifetime risk of psychosis, or all of the above.
Lots of
Ron.
fours popping up already.
Okay, excellent.
Fours all over the map.
Okay, Don, what do you think?
Mute button, maybe?
Everyone should have their hands on their mute buttons, be ready to be called on at any moment.
Because if this continues, I think I'm going to deputize Dr. Hosseini Gomi to lead the charge on cold calling. And he's not nearly as nice. Okay. Ron, we're hearing from you. Okay, how about Maynette?
Anyone?
Maynette Wong, what do you think?
I don't have a medical background, so I would be guessing.
Yeah, please do. That's what this is about.
I guess 4.
All the above. All right. I like it.
This one's
So-
interesting because were you purposely trying to put a distinction between psychosis and schizophrenia?
Ooh, I like it. Let's talk about that. So let's look at the data insofar as the associations. From a systematic review that included 53 studies of patients with schizophrenia spectrum disorders. So essentially this is people with primary psychosis. There was over 20% prevalence of cannabis use over the past 6 months and a 42% prevalence of lifetime cannabis use. We do know, based on numerous case studies, that cannabis-induced psychosis is strongly associated with the use of high THC concentration product. In particular, think wax. Acute THC administration causes increased dopamine release throughout the dopamine pathways in the brain. It would make sense because when we think about the pathophysiology of psychosis, we're really talking about hyperactivity in the dopamine pathways. And because THC potentiates dopamine release, it would make sense that really high THC content product can result in psychosis. What remains unclear is whether this acute effect is related to the development of schizophrenia associated with chronic cannabis use. In a Danish study that used the national registry of about 1,500 patients who were diagnosed with cannabis-induced psychosis over a 20-year interval and then subsequently followed, they found over 40% converted to later meet diagnostic criteria for schizophrenia. This prompts a lot of questions. Is it that patients who have an underlying susceptibility to experience psychosis and maybe are a higher risk for going on to actually develop chronic recurrent psychosis, which is kind of an abbreviated way to refer to schizophrenia, is it that those people are more likely to experience psychosis when they use THC versus is heavy THC, especially use of high THC containing products, likely to cause permanent psychosis, even in abstinence? We don't have definitive answers, but this is a really compelling association. How about cannabis use and the co-occurrence with schizophrenia? From a cross-sectional study, we see that regular cannabis use, especially daily use, is associated with 2 to 3 times higher lifetime prevalence of schizophrenia in comparison to non-users. Schizophrenia was strongly associated with earlier age of onset of cannabis use, higher frequency of use, and use of high THC content product.
So, Dr. Seiss, we have Don Runyon. He's has some information about all kinds of issues here. Take it away.
Me on the spot.
Thanks for joining us, Don.
It's just interesting because in the behavioral genetic literature, it supports this almost always a combination of genes and environment. There's a genotype environment correlation and interaction with these folks that they usually do have a predisposition towards a pathology, and the onset is encouraged or caused by drug abuse, be it cannabis or LSD or things like that.
That's really compelling. And yeah, that's consistently suggested in the literature that, if you will, there's a genetic predisposition to psychosis. So you have the dopamine pathway already in some ways prone to dysregulation and excitation. And then, hey, you put in THC, which we know is going to potentiate release of dopamine. Hey, sure enough, you can see an increased risk of psychosis and potentially chronic psychosis, schizophrenia, almost something kind of analogous to the cancer model of gene and then environmental insults. I like that. Looking to what the data tells us, in addition to what we discussed, in a systematic review, they saw an increased risk of psychosis associated with any lifetime use of cannabis and a dose-response relationship, 2 times increase in the risk among the highest frequency users. This next study is really compelling. In a Finnish prospective longitudinal study, they saw that there was a significant increase in the risk of psychosis among the subjects who used cannabis more than 4 times by the age of 16 versus those who never used. Robust study insofar as the N. This was over 6,000 participants. They were evaluated at ages 15 to 16, evaluated again at age 30, and the hazard ratio was 3. So a 3-fold higher risk of having psychosis if they consume cannabis more than 4 times by age 16. So clearly, we're concerned about early onset of use, especially chronic use of high THC product. So is there causation, kind of going along with the themes that you raised on? We can look at what a cross-sectional study of 7,000 adults in the Netherlands Twin Registry showed. So they had a risk score for schizophrenia that was derived from a large genome-wide association meta-analysis. So they used that risk score derived from the genetic data. They saw that it only accounted for 0.5% of the variance in lifetime use of cannabis, frequency of use, quantity of use, and age of initiation of use. So the authors concluded that the increased prevalence of cannabis use by people with schizophrenia was unlikely driven by some sort of shared genetic liability. In other words, they don't think that a third factor here, be it some sort of genetic mutation, was causing both cannabis abuse and schizophrenia. Perhaps, as you were reflecting, Don, is mentioned again and again in the literature, this hypothesis that there is a genetic liability, increasing risk for psychosis. And if those people who have that increased risk then use cannabis, they're even more likely to experience psychosis, in particular chronic psychosis, schizophrenia. In cannabis use in patients who had primary psychosis, it makes the positive symptoms, the hallucinations, the persecutory delusions, a lot worse. This was confirmed in a 2016 systematic review meta-analysis of 24 longitudinal studies, really robust statistical analysis here, as well as in a 2-year-long prospective longitudinal study. Worse positive symptoms, also more recidivism. People were more likely to have psychotic episodes and require hospitalization. So, hey, rock on, it is all of the above. Look at this participation. People are just crushing it. How about anxiety disorders? Do we select higher rates of cannabis use are associated with anxiety disorders? Among cannabis users, anxiety disorders are more common among men than women. Cannabis use acutely decreases anxiety levels for the majority of people, or all of the above? Any takers?
Seeing a lot of ones come through.
All right, I like it.
Couple threes.
Nurse practitioner Megan Lehman, what do you think?
I think number 1.
I like it. All right, thank you. Let's take a look at the evidence. So very, very strong association from the same secondary analysis we saw earlier about mood disorders and cannabis use. We see that similarly, you see a 2 to 3 times higher rate of lifetime cannabis use in people with anxiety disorders versus those without. From community survey data, we see that among US adults, for those who meet diagnostic criteria for cannabis use disorder, among women with cannabis use disorder, across the board, they have higher prevalence of anxiety disorders, be it specific phobia, generalized anxiety disorder, social phobia, and panic disorder. Similarly increased among men. It's worth acknowledging, though, however, at baseline in the population who is abstinent from cannabis use or uses only occasionally, on average, women more commonly meet diagnostic criteria for anxiety disorders. So sure enough, in those who abuse cannabis, similarly, women are overrepresented in comparison to the male gender. That's probably a reflection of the baseline overall higher level of anxiety disorders in women in general. Across the board, you see an increase no matter what the gender is. Cannabis intake causes transient acute anxiety in many people. It's less clear what happens insofar as long-term use. From a prospective longitudinal community-based study of 35,000 American adults, there was no increased risk of developing an anxiety disorder among cannabis users. In comparison, in Australian 15-year prospective longitudinal study of 2,000 adolescents, so more robust study design, and also we're studying adolescents here, 2 notable differences. They found daily cannabis use during adolescence was associated with a 2.5-fold increased risk of anxiety disorder at age 29. So perhaps it is more deleterious if abused during adolescence, insofar as provoking a higher risk for anxiety later in life. So you rocked it, Megan. How about PTSD? Significant association, cannabis use potentially worsens symptom severity. We see from epidemiologic data that the comorbidity between PTSD and cannabis abuse is around 10%. In a systematic review that combined 4 prospective longitudinal cohort studies of adults with PTSD, they saw that current cannabis use was associated with higher levels of PTSD symptoms over time versus those who were abstinent or hardly used. What about OCD and ADHD? The study designs here are weak, but suggest significant associations. From a household survey in Australia, they saw about 20% prevalence of OCD among patients with cannabis use disorder versus just 2.4% among those who were abstinent. For ADHD, a 20 to 30% comorbidity. And it is worth acknowledging the self-medication hypothesis. I'm going to preface this with saying I share this with care. I don't tell all patients about this. Think about when and how you would want to share it with patients if you do. So there is a study coming from the United Kingdom where cannabis is nationally legal, and sure enough, they can get precisely measured THC extract. And in this study, they enrolled 30 participants, some with ADHD by DSM-5 criteria, others who are quote unquote normal, who did not meet diagnostic criteria. They subjected them to objective cognitive testing and then gave all of them a few days of 3 milligrams of THC daily, and then tested them again insofar as their objective cognitive performance. Remarkably, those with ADHD showed no difference insofar as the objective cognitive performance, whereas those without ADHD did. They didn't perform as well as you'd anticipate. Few things here. This is truly moderate use of THC. The average joint has 5 milligrams of cannabis, and a lot of our patients are using 10 to 20 milligrams of THC daily. At that level, THC causes global cerebral dysfunction. And there is really compelling evidence that these people are not going to test as well as when they're abstinent, even if they have ADHD. But when used in moderation, it's likely that to the extent THC potentiates the release of dopamine, because patients with ADHD experience dysregulated function of the prefrontal cortex, and in particular the striatum, consumption of THC in moderation potentiates release of dopamine in the striatum, and thereby it's somewhat of a protective effect, offsetting the global dysfunction. But the moment they get really stoned, that goes away. It's worth noting the statistical significance here was equivocal. There were a few adverse events. Someone had tachycardia, another had muscle spasms. How about other substance use disorders? Cannabis abuse is comorbid with all forms of substance abuse, in particular with alcohol and stimulants, as well as tobacco. One notable exception with opioid use disorder remains very, very co-occurring, but not as co-occurring in comparison to alcohol and other substance use disorders, only 4 times the likelihood of co-occurrence. Quiz here on cannabis use disorder. Out of every 10 people who use marijuana, how many will become addicted? This is courtesy of SAMHSA. Alyssa, what do you think?
Can you hear me?
Yes.
Hi. Let's see. Goodness. I would say I'll go with 3. I don't know, truly.
So 30%. All right. So the correct answer here is 1, so 10%. Acknowledging this is really significant, right? About 1 in 10 people who use marijuana, this is any use per SAMHSA, will eventually go on to abuse cannabis enough, have some degree of dependence, and also functional impairment, meeting diagnostic criteria for cannabis use disorder. That's a really big deal. And Alyssa, sure enough, it goes all the way up to 1 in 6 for people who abuse cannabis or use it at all by age 18. So takeaways here: overwhelming evidence that acute and long-term cognitive impairments can occur with cannabis use. In particular, it's concerning what happens in the youth population. There's a significant association between cannabis use and mood disorders. High THC consumption is associated with both acute psychosis and increased lifetime risk of psychotic disorders, especially worsening positive symptoms. Evidence is suggestive of a causal link, potentially the change in dopamine pathways that results with THC use, especially if it's high content. Significant association between cannabis use and anxiety disorders. Unclear here what the causal link is, if there is one. Significant association between PTSD and cannabis use, as well as significant associations between cannabis use, OCD, ADHD, and other substance use disorders. How is this pertinent to our patients? So we have folks joining from several states, including, if I recall correctly, in addition to Montana, we have Alaska, Hawaii, potentially some folks connecting from Guam. I think I saw Michigan, if I'm not mistaken. So we can see that across the majority of that geography, cannabis is in some shape or form legally accessible. In the case of Hawaii, only for quote unquote medicinal purposes, you need a green card. In Alaska, recreational sales are up and running. Montana, it is legal for recreational purposes. I think we're going to start sales this coming calendar year. So 2/3 of Americans live in a state where cannabis is somehow legal, with 1/3 in a state where it's recreationally legal. Significant increase in use across virtually all populations, with big spillover in the youth population. This is worrisome, right? We see the worst impact in mental health among youth in comparison to other populations of those folks who use cannabis. So here's where I would engage in self-deprecatory humor, but Mountain Pacific wouldn't tolerate it and remove the photo I put in here. There's a funny one of me. Essentially, I got conned into going in front of the press and really wanted to emphasize what we've talked about here, how frequent THC use is going to make depression worse, anxiety worse, can lead to cognitive slowing. If someone has primary psychosis, it is likely to be more severe and more frequent in its chronicity. And if someone has a history of criterion A trauma, they're more likely to experience trauma-related symptoms and potential worsening thereof. And risk is especially risky for adolescents and kids. For treatments, and hopefully we can talk more about this, because here again is really where the bulk of the therapeutic yield is at. Psychosocial interventions, so contingency management, motivational enhancement therapy, cognitive behavioral therapy, 12-step. This is really where the money's at insofar as getting people to cut down their use and ideally abstain. When it comes to medications, Gabapentin, that we'll look at in detail in a moment, does have statistical significance for helping patients who are motivated. N-acetylcysteine did show some initial promising results when it used to treat cravings for cannabis in adolescents at really high dose. But then this was not replicated in larger studies in the adult population. So Barbara Mason's group at the Scripps UCSD Institute took a look at using gabapentin in a cohort of patients who presented for treatment of cannabis use disorder. It's worth acknowledging all these patients were very likely motivated at baseline because they elected to participate in the study. Total of 50 patients. And across both the placebo arm here on the top, as well as the gabapentin arm, everyone saw a huge decrease in both self-reported use of cannabis, the grams smoked per week, and that was also corroborated by what was on the urinary biomarker here on the right vertical axis. There was a statistically significant further decrease in the gabapentin arm versus placebo. But if you look at that in comparison to the net decrease, that's cents on the dollar. So again, the psychosocial intervention here is overwhelmingly likely driving this. The dose was TID 300, 300, 600 at night. So harm reduction, what about for those patients who just will not, for whatever reason, pursue abstinence? We really want to focus on specific populations at risk, adolescents, people with some sort of other mental health diagnosis or family history of psychosis. Do whatever we can to help them cut back and ideally abstain. We want to decrease overall use, the frequency and the amount consumed, limiting the time of day people use, perhaps only to nighttime, and limit the amount they buy at any one time, and decrease THC potency. No synthetics, and please, urging our patients not to use concentrates. All right, so I will stop the share. Thank you so much. And I know we do have a case.
Question.
Yep.
From Dawn, do you think that chronic use depletes the availability of dopamine?
I know of no evidence to suggest that that is the case. You could see a shift in dopamine receptor responsiveness. And I'll call on my colleague, Dr. Reza Hosseini Gomi, to keep me honest here. I am aware that, for patients who take antipsychotic medication on a chronic basis, you can see a shift in how the dopamine receptors respond. And in many ways, you can have increased rates of psychosis if they ever come off an antipsychotic. Anything that's going to shift what's happening in that dopamine pathway is likely to disrupt its equilibrium. So I would say, it's going to increase risk of psychosis. That may be the pathophysiology. We don't know yet. No evidence that it actually depletes levels of dopamine, given our brain is constantly generating more.
Anybody else has any questions, feel free to put them in chat. Jenna asks, is there generally a safe age? Now I've lost my chat. Safe age to use cannabis without the risk of permanent impairment?
Yeah, so the brain stops developing at age 25. And so, I think in very much like so many things within mental health, oftentimes we're triaging risk. Certainly, whatever we can do, looking at the evidence we just reviewed, let's do whatever we can to prevent use prior to the age of 16. Ideally, if people can hold off indefinitely, that's awesome. What I like to remind patients is it's not like the FDA is controlling the content in the cannabis they're purchasing at head shops, be it medicinal or recreational. It's the states. And we saw in the state of Washington, independent audits show the quality control was non-existent. It's much more like purchasing alcohol back in the 1800s, where one beer could have 4% alcohol concentration, the next 12%. You kind of never know what you're really going to get, short of doing your own study of the product. So I would say, just consumer beware. If someone said, I'm going to use cannabis no matter what, just tell me when I can use it, and it's going to have the least likely negative impact, I'd say wait until you're 25, but certainly, wait at least until you're a legal adult. For cyclical vomiting syndrome, Jennifer Kien is wondering, I've never tried Haldol for that. Largely, it's been supportive treatment, IV hydration if necessary. I've actually been consulted an inpatient on medicine wards to help treat patients for this. We do whatever we can to keep them comfortable, and ideally, use motivational interviewing to help them cut back use. But it's a really challenging scenario. We don't have a ton of time, so I think it's a great time to talk about the case. Dr. Reza Hosseini Gomi, please take it away.
Thank you. So I typed up a bit of a case. So I'm just going to kind of go through it somewhat a little more formally, but please do interrupt with questions or comments. I'm just following kind of a typical case format, but this lecture made me think of an interaction I had where I was treating a young veteran. This was a few years ago, and I really struggled with how to manage the cannabis use disorder. And so I'll start off by just giving you kind of a one-liner. So this was a 26-year-old man with a history of anxiety, PTSD, he's a veteran, mild cannabis use at the time, and he was presenting with increasing anxiety, worsening job performance, and paranoia at the time we met. Now, his background, history of present illness. So this young man was in the military for 4 years, straight from high school until about 22 years old. He had an honorable discharge and started working right away at a private company, and really, for all intents and purposes, was doing overall very well. He did begin treatment for anxiety and PTSD and had good response to both prazosin and sertraline. That was mainly stemming from military exposure to combat. And he had some of the classic symptoms of PTSD like hypervigilance, increased anxiety, social isolation or avoidance, insomnia, some nightmares. And so overall, he had been doing well. And during that time, he had also been using approximately one, quote unquote, bowl at the time. It was not legalized yet. And so he would smoke a bowl, he would say, in the evenings only, just to help him get to sleep and go to sleep, but never during the day. And it was on most nights. And at that point, it did not seem to be interfering with his day-to-day functioning. And he was really set on that it helped him with his anxiety. And so at the time he was seeing me, cannabis, and this was in Washington, where it had been legalized initially, just was a few months prior to him seeing me. And so he began buying vape products because he was able to, get a vape pen and start smoking the cannabis much easier. And so he started taking it to work with him at his company. He was taking breaks, so he was smoking it throughout the day. And he was very convinced that it was helping, that it was overall a good thing. Now, by the time he saw me, he denied any relationship between the cannabis and the anxiety, although he presented for more treatment for his anxiety. And the timeline of his anxiety increase seemed to mirror perfectly the increase in his cannabis use. I also looked up the products. His concentration went way up. So it wasn't that he was just using cannabis more often. The concentration of the products was much higher. And so despite his belief that it was helping, he was now experiencing paranoia. He had a lot of this, thought someone was following him, thought someone was out to get him. He was becoming more and more just sort of standoffish, isolative, even to his close friends. I did get him to agree to let one of his friends come and take his firearms because he was starting to get, almost like, standing by the window to his apartment with a gun, that kind of thing. And so he was somewhat, agreeable, but he was losing insight, losing ability to understand what was going on. Didn't really have any medical history to speak of, social history, pretty straightforward. Overall, otherwise healthy kid. He was living on his own, had a good job, finished high school, had a decent support network before this all started. He didn't use any other substances. He drank alcohol very occasionally, light use. So that was also made it a little bit easier in terms of not having any confounders. His family was in Michigan, so he was not near family here. And so when he presented to me his mental status exam, he was presenting more over time. I saw him for a few visits in a row, and he was presenting more disheveled. His hygiene was decreasing. His eye contact was also decreasing. He was getting a little more avoidant of eye contact. His a little more paucity of speech or less spontaneous speech. His volume was a bit quieter. He reported he felt anxious. He didn't really identify a lot of depression or suicidality, but just mainly anxiety. But and his thought content was such that he worried about being followed and that someone was trying to get him. Although it was very non-specific. He couldn't identify any specific individuals. He was socializing less. His friends were having a harder time reaching him, staying more in his apartment. And things were pretty much falling apart at work. He was really not doing well at work. And he was starting to miss a lot of time. There were days where he just wasn't going to work. His thought process was perseverative on his paranoia, and he had at that point poor insight and judgment. And so in terms of assessment, I diagnosed him with cannabis use disorder severe with psychotic features. And I started him on risperidone, thinking about, okay, I was trying to get him to reduce his cannabis use, which he was somewhat agreeable to, but it was, he never stopped using it. So that it was really hard to try to make progress there. So I turned to antipsychotic. He had very poor adherence to it, and it's to nobody's fault. No one wants to take antipsychotics to begin with. So it's a very difficult medication class to be adherent to. And so he ended up being lost to follow-up. He no-showed for a couple appointments. This was actually at the Addiction Treatment Center. So we had pretty good, support. So we were trying to track him down, nothing happened. And then weeks later, I tried calling him. He finally answered his cell phone, and he was extremely psychotic. He was said he was at a gas station in Indiana, I think. He said he had just been driving around the country for weeks, running away from this person. And he said he was whispering. He said, "I think I can see them. I think I can see them. I'm looking out my window. I think they're behind me." He wasn't suicidal. He didn't have any weapons with him. And the story ends with me. I somehow got him to agree to go to I looked up the closest VA. And so he drove there and he got hospitalized. And I don't know if he ever came back to Seattle, but kind of handed him off to the local VA there. But my questions around this case have to do with how best could I have treated him? What could I have done differently? Anything I could have done to help his adherence to treatment and intervene potentially earlier or maybe more firmly, because he definitely had like a pretty gradual decline, but before he kind of hit that, severe psychosis state.
Dr. Sanigomi, thank you so much. This is a really compelling case on a lot of levels. What I'll attempt to do is quickly summarize, just in a really brief identifying statement with chief concerns. 26-year-old gentleman with PTSD and cannabis use disorder who, while he escalated the dose of THC he was using in his cannabis, presented with increased positive symptoms of psychosis, as well as, it appears, some negative symptoms, potentially some social withdrawal, decreased function, as evidenced by the hygiene, as you aptly identified. You're thinking about how you could have best engaged him in treatment, acknowledging that you started an antipsychotic, he struggled to adhere, and ultimately kind of fled the area.
Mm-hmm. That's correct. Yeah, I'd be curious what other folks think in terms of treating this kind of situation.
This is Malcolm. Did he do any behavioral therapy as well besides the medication, like any motivational interviewing? I mean, we've had a few patients like that where it's hard when they're psychotic to really try to get through to them because their reality is a little bit different, but certainly, was he at all, it sounded like he had a little bit of opening, a little bit of insight to trying to do things, would motivational interviewing, even educating him, like we should have just had Dr. Seiss educate him about all the research, right? Sometimes I think patients don't know, of course, if he's in that altered psychotic state, how much of it could he have really taken in? He may have thought you were just trying to take his meds away from him. You're trying to take the pot away from me back in, I don't know. So I was wondering about like any behavior therapies that he would have been appropriate for or useful for him.
Yeah, I think that probably was a point of improvement I could have done. Other than brief MI within my sessions, I did not connect him at the time to, I would say, I don't think I brought it up strongly, but he didn't fight it per se, but I didn't push hard for him to engage in therapy.
If we think about the stages of change, where would you have put him?
He really wasn't even pre-contemplative. I mean, he was very set always on that cannabis was helpful, and he never wanted to really fully give it up. He was willing. I mean, there was a period in there where he, reportedly lowered his use to try to give a break. But at that point, I felt like maybe that snowball effect had happened, and so I wasn't sure if he truly decreased or if it was really enough of a decrease because of how much he was using. But even up until I was able to get him into that other VA, I mean, he still was, he was smoking and was very committed to it.
Any family history of psychosis?
No.
Okay.
This was a little earlier in the chat box, but Dawn had, I'm just going to paraphrase, that some heavy users of pot seem to experience motivational problems and isolation.
Mm-hmm.
Melissa, would you like to speak to the point you just made in the chat?
Sure. I don't know if this one's useful. I had a patient with a similar situation. She had never had any psychosis before, but she ended up being hospitalized with some pretty severe delusions and hallucinations. She was using a large amount of marijuana, and a family practitioner, she complained of anxiety and depression. So they had started somewhere else, Zoloft for her, and she continued to have the psychosis while taking that. She had to be hospitalized as well, like your patient. And then it wasn't necessarily addition of medications, but removal of that one seemed to help her come back out of it. And they had her on Abilify for a little bit. She's not on that anymore. Now she's just taking, I think, Seroquel, and I think Prozac. But yeah, it seemed like the sertraline and the marijuana together, and then there was some speculation that maybe a sudden stoppage of the high dose marijuana use might have contributed as well. So I'm not sure about that.
Certainly, you can see rebound anxiety with abrupt cannabis cessation, and that's something we leverage Gabapentin for all the time. The physiological withdrawal from cannabis is nowhere close to what you see in benzo cessation or alcohol cessation. That said, it can make patients really anxious. And if somebody already has a proclivity to psychosis to begin with, that can be really destabilizing. That's really compelling to hear. Per your description of the sertraline, I'm left wondering, do you know if there's any family history of bipolar disorder?
She was diagnosed with bipolar disorder, I think, subsequently, and then I think that was a piece of that, and we got that added to her allergy list so that we don't do that again.
Yeah, that's really compelling. You wonder, what role cannabis played in potentiating psychosis versus was this a mixed mood episode, manic episode launched by a serotonergic medication? It's really compelling. Reza, for your patient, were you left wondering about primary psychosis?
Yeah. He had a remarkably, even when he was taking the risperidone, as far as he reported, it was, the psychosis really wasn't budging. And so it was interesting, yeah.
Was there any improvement in the negative symptoms? Social withdrawal, the overall function?
Well, I had him. He kind of went down that rabbit hole. And I didn't get a chance. I never followed up with him to see how he did after that hospitalization. It was lucky his parents were in Michigan, so they were willing. I was able to get in touch with them, and they drove to get him, and then they brought him to the VA. So that was really lucky. I don't know if subconsciously he was going closer to home. I don't know if that was part of it or what, but yeah, he ended up being close to home.
We have a comment from C. Allison.
Yes. Yeah. There's also a question about his sleep pattern.
Oh yeah, sorry, I missed that. No, I'm trying to remember the sleep pattern. He certainly, later on, it was erratic, disordered sleep where he was so paranoid, but that would be the most I can comment right now based on my memory.
And then C. Allison's question, and keep us honest here. I understand this to mean, would we, for the two patients we just discussed, and the one that Melissa Bates mentioned, and then yours, Reza, would we favor psychiatric hospitalization versus outpatient in Malcolm Horn? Yep. So often it is a negotiation because, especially here in Montana, Wyoming, similar. I'm not familiar with the mental health laws in Alaska. I need to educate myself, but I think it's likely somewhat similar to what we see here. People really have to meet the criteria of danger to self, danger to others, or grave disability, inability to basically care for themselves. And so often they don't meet that threshold. So it's not like we can compel treatment and then motivating them to come inpatient. It's tough. But certainly when possible, especially if they're actively responding to internal stimuli and can't take care of themselves, it's something we favor. Then Don, did you want to, well, it is 4 o'clock. You made a mention of potential role of personality. And then Melissa was talking about availability of treatment. This is good participation. Thank you. Amber, would you like to bring us home?
Sure thing. I did put in the chat, and I'll do it again, the link to make sure you fill out the attendance link, and then also the evaluation forms. And we are always looking for cases, so please feel free to reach out to us, and we will get you a case form.
And please join us next time for opioid use disorder, pandemic proof. We'll be talking about some pretty compelling stuff. Thank you all. Thank you, Dr. Hosseini Gomi. Thank you, Dr. Horn, Amber Rogers, Mary Argonis. Thank you all. Take care now.
Awesome. Bye-bye.